surviving of patients who suffer an out-of-hospital cardiac arrest is very few. But even if the patients return to spontaneous circulation, many of them suffer cerebral damage. So it has been recommended that patients who remain comatose after an out-hospital cardiac arrest should be cooled between 32 and 34 degrees for 12 to 24 hours to prevent damage. Animal models suggest that for every degree in reduction of the temperature in the cerebral metabolic rate decreases by 6%. Now we have new devices with those devices it's possible to maintain stable levels of temperature. So we have the hypothesis that with colder temperatures will be associated with better outcomes in survival and neurological outcome. So the aim of this pilot study was to obtain initial data on the effect of different levels of therapeutic hypothermia in survivors of cardiac arrest. The inclusion criterion of the trial was witnesses out-hospital cardiac arrest with an interval less than 60 minutes between collapse and returns of a spontaneous circulation, and the initial rhythm should be a shockable rhythm or a systole. There are several exclusion criteria, such as the presence of cardiogenic shock or Glasgow coma scale after return of a spontaneous circulation above 8, and known terminal illness present before the out-hospital cardiac arrest. This is the flow chart of the study. During the study period, we screened 73 patients with out-of-hospital cardiac arrest and in coma, and 37 were excluded for several reasons. The most important reason for exclusion was that representatives refused to to participate in the trial. The remaining 36 patients were randomized and were stratified according to the initial rhythm as shockable rhythm or a systole. So 18 patients were allocated to 32 degrees and 18 patients allocated to 34. These are the baseline characteristics that are similar in both groups, except in what's respect to dyslipemia that was higher in the patients assigned to 32 degrees, and the trend to higher incidence of hypertension in patients assigned to 34. Here are the CPR characteristics. I would like to point out that most of the median Glasgow coma scale was 3 in both groups, but and also the time from collapse to return of a spontaneous circulation there was a trend to less time in patients assigned to 32. Here are the primary outcome of the study. The survival free of severe dependence at 6 months. Patients assigned to 32 degrees survive free of dependence in 44.4% of the cases, and compared to 11.1 in patients assigned to 34, that did not reach statistical significance. But if we analyze the patients according to a pre-specified subgroup, patients assigned to patients with initial rhythm of asystole and patients with initial rhythm, a shockable rhythm, we can see that patients with asystole, all of them died before the 30 days of evolution. But in patients with shockable rhythm, the patients assigned to 32 degrees had better outcome with a p-value of 0.2, with a survival rate of 61.5 compared to 15% in patients assigned to 34 degrees. There are also several secondary endpoints are shown here. The death rate was lower in patients, significantly lower in patients assigned to 32 degrees, and also the neurological outcome was better, a trend to better neurological outcome in patients assigned to the lower temperature. And if we consider only the patients with shockable rhythm, the neurological outcome was significantly better in patients assigned to the lower level of temperature. Here are the complications of this treatment. We can see that the incidence of seizures was less prevalent in patients assigned to the lower level of temperature with a significant p-value, 5% versus 61%, and also there was a trend, on the contrary, of higher incidence of bradycardia in patients treated to the lower level of temperature. The study has limitations. The most important one is the sample size and the variability of prognosis of these patients. And as you see here, as you've already seen, the lower risk profile, although no significant, was present in patients assigned to 32 degrees. Also, an important limitation that there was an absence of blinding of the nurses who care the patients, but the neurological evaluation was blinded to the temperature assignment. Also, patients with assigned to 32 degrees were longer periods of time below 34 degrees because there was a longer duration of induction and longer duration of rewarming. So I think we can say that this pilot trial suggests that cooling target to 32 degrees may improve outcome of out-hospital cardiac arrest patients secondary to ventricular fibrillation or pulseless ventricular tachycardia. But obviously further investigation is needed to address the optimal level of hypothermia in this challenging clinical situation. Thank you very much.